Assalamu alaikum dear doctor. In this video I am discussing about myocarditis history and everything. So first, just simple myocarditis. What it causes? Myocarditis causes the heart muscle to become thick and swollen. Now how history come in myocarditis? The opening statement or chief complaints is like recent upper respiratory tract infections. 1 week later came with fever, malaise, tachycardia and weak pulse. So myocarditis is an acute problem and it is an acute history. Now introduction is similar and history of present illness, complaint analysis plus review the systems. So we are analyzing what is the main concern. Fever, awareness of heartbeat, fainting, chest pain, inability to walk. Okay. When did this start? Which symptoms started first? Is it increasing or decreasing? Is it what did you do for it? Associated any other symptoms like rigors, fits, night sweating, swollen glands. So the fever is associated with this symptom, we will ask. In general, how the child is, activity, appetite and sleep, we ask. Then the systemic review we go, CBS we ask that any history of fainting episodes, exercise intolerance, blue lips, awareness of the heartbeat, blood pressure measured. Chest we ask recent cough or cold, difficulty in breathing, noisy breathing, snoring during sleep, asthmatic, recurrent chest bugs. CNS we ask any headache, weakness, facial asymmetry, eye deviations, any concern about vision, hearing or speech, unusual walking pattern and change in the mood. Urinary system we ask change in the pee, amount, color, frequency, pain in loin, pain during peeing. Musculoskeletal system and skin. So pain during peeing, I think that is UTI excluding. Next, musculoskeletal system and skin, we ask any skin spots, muscle weakness, difficulty in climbing stairs or in getting up, swelling hands or feet, bone or joint pain. Swelling hands or feet like Kawasaki disease, we know that there is peeling of the hands and feet presence. Now GIT we ask tummy distensions, tummy pain, throwing up, especially in the morning, change in poo, hematology, any pallor, bruises, bleeding and bugs. Endocrine we ask that cold intolerance, blood glucose test. Other concern the dysmorphic features, long-term medical conditions or chronic illness. Then we go for past history. Past history we know that the mnemonic is 5T IOA. So 5T trauma, treatment, involved, blood transfusion history and any traveling history. IOA is that investigation, onset and admission in previously. So we ask in past history, taking any medications, COVID contact, COVID vaccine to close contacts, hospital admissions, follow-up with team and recent travel. Perinatal history will ask any event in pregnancy, jelly scan results, newborn screening and ICU admissions. Puberty we ask that it is started the menstruation, is it regular, boyfriend, OCP and protections. Vaccination we ask, allergy we asked and nutrition on a special diet, type of food, amount and growing chart we exclude. Then normal development history we take, the family history we take, school, social and psychosocial impact we will ask. That is the history we take, and in this history what are the DD come on our mind. It is a disease of fever with cardiac symptoms. So the DD are myocarditis, that is viral origin, we know that. It can be pericarditis, infective endocarditis, rheumatic fever, Kawasaki disease, PIMS that is COVID and systemic onset of JIA, pneumonia, meningococcemia and sepsis. Now, what are the causes of myocarditis? We know that causes of myocarditis, that is infection, viral causes are influenza, SARS-CoV-2 virus, COVID-19, Coxsackie ANV, parvovirus B19, respiratory syncytial virus, adenovirus, Epstein-Barr virus, herpes zoster virus, HHV, and HIV, cytomegalovirus, polio, and rubella. Bacterial causes of myocarditis are Lyme disease, tuberculosis, typhoid, diphtheria, and sepsis. Fungal cause, parasitic causes are Toxoplasma, Chagas disease, that is Trypanosoma cruzi. Now, immunodisorders. That is SLE, systemic onset of GIA, dermatomyositis, rheumatic fever and inflammatory bowel disease. Drug-induced are doxorubicin, that is chemotherapy, metabolic are hemochromatosis and hemosiderosis. Endocrinal are pheochromocytoma and hyperthyroidism. Nutritional are hypercholesterolemia, kwashiorkor, protein energy malnutrition, weight beriberi. Then coronary abnormalities, Kawasaki and congenital abnormalities. Hematological causes are anemia, thalassemia and sickle cell disease. What investigation do we for this case? That is, for blood, we do the full blood count, peripheral blood film, blood culture, inflammatory marker, ESR, CRP and ferritin level, cardiac enzymes, that is myoglobin, troponin, T and I, CKMB, BNP and LDH, D-dimer, urea and electrolytes, creatinine, liver enzymes, viral PCR, viral antibiotics. And ECG, we find sinus tachycardia, ST segment elevation, then ST segment inversion, QRS and QT's prolongation, low voltage, severe disease, arrhythmia and V tach. Now, imaging chest X-ray, we find cardiomegaly and echo, we find low ejection fraction. What is your management plan for this patient? That is first ABC, airway, breathing and circulation, admit to the ICU unit. If the child is in pain, I will give analgesic if shocked. Then give shock therapy on 10 ml per kg for fear of volume overload, Repeat if needed. Discuss with the consultant for inotropic support, dopamine and dobutamine for hypotension and low ejection fraction, antibiotic that is empirical then according to blood culture, steroid for inflammation, IV immunoglobulin diuretic if volume overload, antiarrhythmic if arrhythmic, mechanical ventilations. What is the prognosis of this patient? Most will recover, but some of them will have permanent cardiac problem. Treatment is mainly supportive to maintain the cardiac function until the inflammation is subsides. Complications of this condition is dilated cardiomyopathy, heart failure and arrhythmia. So this is all about myocarditis history and discussion. Please do subscribe and share MRCPCH with Dr. Emma Choudhury. Thank you.